I've been in the ambulance service for 21 years now, I think it is. I have a lot of different roles in the ambulance service. So I have a leadership role where I look after 5 ambulance stations. It's all gone funny, there you go. And I have a clinical role as well, so I operate as a critical care paramedic and also a HEMS paramedic for Air Ambulance Kent, Surrey and Sussex, which is the role that I've been asked to talk about today. So I entered the ambulance service as a traditional ambulance technician, training ambulance technician, and became a paramedic through the old IHCD pathway. And it was during my time as a technician and then latterly as a paramedic that I developed an interest in pre-hospital trauma care and critical care. And it stemmed from, as you guys will see out on the road, that trauma teams and HEMS teams tend to have quite a different approach to that which ambulance personnel traditionally display, traumatic incidents. And there's a lot of reasons for that. There's certainly no blame on anyone who operates in the ambulance service for this sort of thing at all. I think it's totally down to the amount of training and exposure you get to this stuff. Do feel free to have a camera on if you want to. It's nice to see a face to talk to. Thanks, Hannah. I really appreciate it. I'll talk to you. Thank you also, Sarah. That was kind of what piqued my interest. It was like I was turning up at these incidents and being told to do things that were fundamentally different to what we were actually doing from experience and our initial training. And so it sort of always just landed as something that I'd want to do. Interestingly, one of the things I was always going to have to get over was I hate flying, or I did anyway. And that was always a bit of a worry for me. So that got me interested. And to start off with, what I really did was just read an awful lot around models of trauma care, the academic papers that were starting to emerge, the Trauma Who Cares agenda, and so on. And I started aligning myself a bit with the HEMS team, so actually taking an interest in what they were doing. They started knew who I was, they'd know my name at least and things, and that was always a good thing. And turning up at, we have governance days. So most HEMS systems operate clinical governance days, which are largely open access within reason. So you can't obviously have 100 people turn up at a clinical governance day, but it's fairly easy to book onto one of those, and that's where they train and so on. I'll talk about that a little later. So in any case, I joined South East Coast Ambulance Service and I developed really unusually a leadership role alongside a clinical role. So I became an operational team leader and then I became a clinical operations manager. That was like a station officer, but I stayed very clinical in doing all of this. And then I was able, because my ambulance service were really good like this, to become a CCP at the same time. So I went to the University of Hertfordshire and completed a postgraduate certificate in critical care for the ambulance service. And then I actually, I really wasn't the most academic person that ever existed. So I carried on all the way through to the master's degree and completed it. So when I started, they sold that as a pathway. And I sat there thinking, yeah, right, I'm going to do a master's degree. And I just got the bug. So I carried on right the way through, and that was funded by my ambulance service. And that's not a prerequisite to get into HEMS at all, but it kind of looks willing, doesn't it? So at least you're going along and you're sort of picking up the experiences that they'd be hopeful of. So following on from that, I developed an association just from my own doing with Kent, Surrey, Sussex Air Ambulance, that's now Air Ambulance Kent, Surrey, Sussex. They're like a rebrand. And essentially that involved just, again, going along to their governance days, and they were kind enough to let me go out on the helicopter a couple of times as a third manner. So that was really to try and get over the idea that I hated flying. And I can honestly say we had a little McDonnell Douglas 902 helicopter. It's the same one that flies around in London, that sort of thing. And I was absolutely terrified of the idea of getting on it. And once I got on it, within about 3 minutes, I thought it was the coolest thing that ever existed. Still got a bit of anxiety around it, but actually it's really not bad at all. It's like being on top of a really tall building. You're enclosed. You're never more than 1,000 to 2,000 feet up, so it's not like flying on a jet where you're above the clouds or anything. And the pilots that we recruit are incredibly experienced people, largely come from the military, so they're used to flying around with people shooting things at them. So they're pretty good at keeping the aircraft safe, and safety is a really big part of it. So I then applied to join the Kent Surrey Sussex Air Ambulance, and the prerequisites are simply being a paramedic, and they like 3 years experience as a paramedic, and nothing more than that really. I'll go through some things that will make you stand out a bit more than that shortly. So there's an application process, which is a typical NHS jobs application process. You complete a form, and if you get shortlisted, they invite you to an assessment centre. The assessment centre is taxing as anything. So it's designed to try and see how you operate in a variety of different situations, and what your critical thinking and clinical reasoning are like for the type of patients we're going to see. But an awful lot of it is about how you engage with other people. So while it might not look like it, they're actually testing how you behave in a group of other people, and they'll give you some actors that are incredibly challenging to just see what you do. That will be in the form of 10 mini station clinical assessments, and they'll range from somebody who's fallen off of a building to somebody who's suffered a cardiac arrest, to somebody who's been to 2 people that have been stabbed, I remember, as one of the stations. And one of them's got an isolated stabbing to a limb. One of them's been stabbed in the chest and hems are far out. And literally the pass on that station was an ambulance crew turn up with you. You put that chest stabbing into the ambulance and they just go. There's a paramedic on there. Get them to hospital quickly. Don't wait around. And that's all they're looking for on that station, but it carries on for a lot longer than that. So that's how the stations go. And then if you're successful through those stations, you then have an interview, standard interview. They'll ask you some questions, see what your knowledge is like around the sort of key academic papers that are around, and the trauma agenda within the NHS and how air ambulances operate. And if you pass that, then you're offered a place. So then you go into training. And again, that is really taxing. I spent probably the entire time of that just feeling absolutely exhausted, because it's on the go the whole time. It was a 14-day crew course, and there's a mix of theory and practical. So we call it moulage on HEMS, which is essentially just drill training. And they'll go through sort of things like that's okay. They'll go through things like airway management, rapid sequence induction, which is a huge thing that we do. Like we do an awful lot of that. Multi-casualty RTCs, and just sort of seeing how you perform, how you behave, and how you put your new knowledge into practice. And it's really just designed to generate muscle memory, so that when you turn up at the incident, you've drilled it so many times, you just know to do the same thing over and over again, because most of trauma care is pretty much algorithm-driven medicine. So people find it scary because it's usually a bit gory, quite graphic scenes and things, but actually it falls back to recipe card medicine, where we do the same thing over and over again really, really well. What I should have said at the beginning of this is, if you have questions at any specific point, do feel free to just pop a hand up. I am monitoring them and I'm more than prepared to take questions during. So that's the training side of things. And then some of the air ambulances operate in different ways. So you have HEMS systems that are like Kent Surrey Sussex and London's Air Ambulance, and they're very geared towards trauma patients. So people, trauma at the end of the day, but stabbings, RTCs, falls from height, etc. And they do very little medical. And then you have others that are like Cornwall and East Anglia, and for obvious reasons, they tend to go towards medical patients. They do trauma, but they tend to gravitate towards the medical side of things because of their geography. They're very far away from hospitals a lot of the time, and the helicopter offers a really good way of getting patients that are far from hospital to hospital quickly. They generally travel as the crow flies at 150 miles an hour. So it's a really good tool to use. They also have different requirements as far as what a paramedic's involvement with them is. So in the system that I operate in, we started off with the paramedic actually becoming part of the helicopter crew. You become what's called a technical crew member. So you have to go through training on the navigation of the aircraft, how to operate the navigational systems in the aircraft, how to basically support the pilot in flying the aircraft, though you don't get to fly the aircraft, just to be clear. But you get to do all of the bits that keep the aircraft going in a safe manner, and an awful lot around aircraft safety, putting out fires, all of that sort of stuff. And then you have 2 pilot systems. So we've gone to a 2 pilot system, which I honestly prefer. I miss sitting in the front of the aircraft a bit, but I do have a preference for it. because two pilots adds a bit of redundancy if anything happens to one of them, and they both really know what they're doing. So it's quite a better thing in my opinion. But there's two different models there. Depending where you go, you might get to do some aviation if that's what interests you, or even align yourself with an air ambulance service that suits your needs as far as that goes. As a crew, that's different as well, depending on the air ambulance service you work for. So some services operate whole paramedic crew, so just two paramedics or a paramedic critical care paramedic. And they tend to be the ones that are more geared towards using the helicopter as a transport mechanism, because the geography is very diverse. There's islands that they serve and so on. And then you have a doctor para model. So London Air Ambulance and Kent Surrey Sussex are a doctor paramedic model. And we talk an awful lot about the doctor paramedic partnership. So just to be a little interactive, can anyone think of why it's a really good idea to have a doctor paramedic partnership as opposed to a doctor nurse or doctor doctor or anything else? So that's okay if you don't. So essentially, if you think about physicians, they traditionally work in buildings. It's somewhat unusual unless they're combat. Oh, there we go. Somebody's put some things in. We have experience about how pre-hospital works. And that's exactly it. We do. Most physicians work inside buildings, or they might work with the military and things, but that tends to be fewer and further between. But what they are is very good at medicine. They've trained for years to be good at it, and we only take people that are in their last phases of training, so senior registrars. What they won't have done is worked in the hospital, the pre-hospital arena very much. So we tend to provide the logistics and almost the etiquette of performing in the pre-hospital world, understanding what the challenges are, how to interact with people, how our systems work, where our hospitals are, what they do. And the doctor tends to provide the ability to deliver advanced care, but that doesn't mean it's only the doctor that delivers it. So as a HEMS paramedic, I can do a variety of things that I wouldn't be able to do if I wasn't working alongside a doctor. And again, I'll talk some more about that in a bit. So I've got a bit of a show and tell, so it's not just me talking, and they're just pictures that are going to prompt me to talk some more about things. So the first one, we obviously deal with road traffic collisions. This is a road traffic collision I attended. It's on national media, so no confidentialities are broken with any of these. It was a while ago. That was once a transit van, and the lorry that you see just in front of it fell over on top of it. So that's an extreme example of a type of job that we might deal with. Now, believe it or not, and it's really hard to believe, the guy that was in this was squashed up into the tented section of the van and came out with very minor injuries only. He was actually able to self-extricate once we managed to cut the van away from him. It was one of those go away and buy a lottery ticket type moments. He did really well out of that. But RTCs are really common for us. What I found over the years of doing this, because I've been doing this for 10 years now, is that modern cars are kind of putting us out of business a bit, because the safety features really are second to none. And unless they have a very high speed impact, or they impact an inanimate object, trees and things, actually often they do a really good job of protecting the drivers. So that's RTCs are obviously very common. Falls from height are also exceedingly common for us to deal with. This is the King Street car park in Maidstone. Again, it's off of Kent Online. There was a 16-year-old girl standing right at the top of this, and she jumped and landed on her legs, and she broke both of her ankles, and again completely survived. Totally unbelievable. I remember very distinctly saying to the police officer that watched her jump. She didn't really jump from the top though, did she? It's like, oh yeah, no, really, she can't have just jumped from the top. No, she really did. We watched her. She landed on her legs. I've never seen somebody survive a height like that with such trivial injuries. But we do a fair few falls from height as well, and unfortunately, the outcomes from those are often much worse. Cardiac arrest. We do get a bit involved in cardiac arrest, but we've got a good critical care paramedic system in CCAM, which Kent, Surrey and Sussex serve. And largely they're the experts at dealing with cardiac arrest. The ones that we come into our own for are where they were a very short time in cardiac arrest and they've been shocked and a ROSCA's been obtained. but unfortunately, because of their downtime, they're very irritable still, and they need a pre-hospital anaesthetic, which is outside of the scope of critical care paramedics currently. So we see a few of those. We're also very good for flying them to cardiac arrest centres, where they're known to do better than if they go to a local ED. Stabbings, we get a fair bit of knife trauma. I've never actually seen a shooting since I left the London Ambulance Service, but in certain areas of our trust we get a lot of knife trauma. What we bring to these is the ability to do some surgery if certain internal organs have been harmed, and we are a really rapid transport mechanism to a major trauma centre with these. When you've got any sort of penetrating trauma, the best gift that you will ever give, please take this home with you, is a really, really short scene time. So if you know HEMS are coming, get them to the helicopter's side. We carry blood, we can work with them to try and stop them exsanguinating before they get to hospital. Being on scene does nobody any favours whatsoever when it comes to penetrating trauma. Equestrian. In our area, there's an awful lot of horsey type people, lots of stables, and as you can see from the trajectory this poor person's taken, you can really injure yourself coming off of a horse. So I've dealt with people who have broken their necks or been thrown into trees and suffered serious chest pathologies as a result of coming from a horse. So we see these quite a lot. Burns, self-immolation. I've had a couple of patients that have set themselves on fire. They provide exceedingly challenging airways that are pretty much outside the average paramedic's ability to deal. So we come along, we're very good with, again, giving them an anaesthetic and being able to cope with a very swollen airway that's going to have a pathway where it gets more and more swollen and it's going to become more and more difficult to actually manage. And you obviously get really cool views like these over London at St George's helipad. And sometimes people give you free ice cream as well. So there's even more benefits to coming and working on a helicopter. So that's my show and tell bit in any case. But I do absolutely love what I do, even though I only do it as a part-time matter these days. So I suppose the next part is, what do we offer? And the honest answer is, I think the thing we offer the most is the basics done really well, because we see a cohort of patients that are uncommon and we see them all of the time. So when a typical paramedic sees them, they aren't sure how to react, and an awful lot lives with the way we teach people now, I think. And the fact that services are so pressured, they cancel key skills quite frequently. So you don't get this drilling over and over again to be able to cope with the workload that you're going to. And that, again, that lives entirely with the ambulance services. That's not an individual clinician's fault or problem. When I started, the training was continuous. And now in the NHS ambulance service, it's usually cancelled because we've got winter pressures or anything along those lines, which is tragic in my opinion. We're working very hard in CCAM to change that story. The other thing that we do really well is the primary survey. So again, it's something that people forget within a few years of coming away from whatever medium they use to graduate. And doing a really good primary survey, airway, breathing, circulation, and then identifying any injuries to work out where the patient's best suited to go is, again, something that we bring to the party, because we do it and we're drilled in doing it. And if we don't get it right, we're told off in a very constructive way, but we'll have a consultant in pre-hospital medicine there saying, no, you've missed this, no, you've missed this. And they will just keep steering us back until we're doing this 100% right, as much as we possibly can. And we bring along things like hemorrhage control as well. So again, we're very geared towards seeing people who are bleeding and knowing how to stop that with direct pressure, hemostats, with replacement of blood products where it's necessary as well. So most HEM systems now carry blood. They carry fresh frozen plasma or freeze-dried plasma. Now, if you're bleeding, the last thing that you want is sodium chloride put into your body. All it does is dilutes your clotting factors, increases your blood pressure and makes you bleed more. If you've got a patient who's got a reduced GCS, I'd say that sodium chloride's the best of a bad bunch. It's what you've got, it's what's available, and it's what they probably need. But we don't actually give product to people until they've lost verbal contact with us, because we know pushing their blood pressure if they're bleeding is not a good thing to do. We are very most commonly associated with providing pre-hospital rapid sequence induction. So that's an emergency anaesthetic outside of the hospital arena. It's probably the thing that we train and drill the most. So there's groups of patients that will really benefit from these, and they can be isolated head injuries. They can be patients who have suffered a polytrauma, so they've got multi-system trauma and a reduced level of consciousness. Patients who have broken so many ribs that they can't actually breathe for themselves anymore and they need positive pressure ventilation, and so on. And at the moment, this is something that's outside of the scope of anyone other than a doctor in the pre-hospital environment. So it's something that you need a doctor paramedic team to come along and provide. It also reduces the morbidity of the patients in that obviously if they're asleep with good anaesthetics and analgesia, they're no longer suffering from the pains of their injuries and so on. And you could argue that there's less emotional trauma if they're not awake while they're going through that as well. It's known to improve patients with head injuries by being able to regulate their intracranial pressure and their oxygenation and the offload of CO2. And you know, so many benefits, but that's the one that people usually associate HEMS with the most. There's so much more we can do beyond that, but it's one of the things that we do bring a lot. We have a vast selection of drugs that most people, again, in the ambulance service are unaware of. So we carry a sepsis pack, we keep ceftriaxone, acyclovir for meningitis. So I'd say if you're short distance from the hospital, just take the patient to hospital. If you're going to be a 50-minute drive from the hospital, because some of us are very rural, it's probably worth getting the HEMS team out if they carry that sort of thing to treat your patient with. We keep thrombolytics, we keep advanced antiarrhythmic agents. You know, there's a lot of things that we can offer to people outside of the scope of the trauma patient. So it's very much worth thinking of. And then we get into the other things that you'd be exposed to if you were doing HEMS. So we have surgical interventions that we carry out. The simplest one of those is thoracostomy. So essentially it's a proper needle chest decompression done with a scalpel and a pair of forceps in the side of a patient's chest. Much more likely to decompress a chest and release a hemothorax than a needle is. And that's inside the scope of critical care paramedics in some systems now as well, but only in cardiac arrest patients. There's also thoracotomy. I haven't put a photo of that up because there might be squeamish people around. That's the part where we do a clamshell thoracotomy. We cut somebody's in virtual half, lift up their thorax, get at their heart. We can deliver tamponades from the pericardium. We can give intracardiac CPR. We can actually just manually squeeze the heart. We can sew wounds in the heart. And this is something a paramedic can get involved in. So I get involved in cutting somebody's chest open. That's something I'll hold the scalpel on one side, doctor will do it on the other side. We'll meet in the middle somewhere. We do that surgery together. It's probably the most advanced thing that you'll be exposed to as far as that goes. We also do it sometimes for blunt trauma. I think that there's a limited evidence base for it, but if somebody's bleeding below the diaphragm, we can put compression on the aorta and clamp it to stop any bleeding going on south of the diaphragm, which again, I'm not sure that it saves a lot of patients. I've never seen a patient in our system saved for it, but it's not for the want of trying. There's some soft benefits that you get from working with the air ambulance service as well. So you get clinical governance and training like no other. So there is a training session that goes on every single week, which is known as a clinical governance day. Those are whole days where they will talk about cases that have gone on, and we will literally forensically dissect the cases to understand what could have been done better, what was our on-scene time like, because our patients benefit from short scene times. You know, did we give the right medication? Was blood indicated and we did or didn't give it, and so on. And it's all done in this environment that's not punitive, it's not accusatory, it's totally a learning culture. Nobody gets in trouble in HEMS. It's always a learning culture. And it's really refreshing because then everyone is just completely honest when they're around the table. So that's something that I've really taken away from it, is I've learned more than you could ever believe. And the experiences are transferable to ambulance life. You'll take away how to do a really good primary survey and identify rib fractures down to the rib number with you when you finish on HEMS. Some HEMS systems will let you stay emeritus, which is what I am. So I do a couple of shifts a month now. And you get the best of both worlds. And some air ambulance systems, so my one does, offer 50-50 contracts or 25-75 contracts, so you can do other things as well. The next steps of this are how do you make yourself stand out for selection? So if you are seriously looking at HEMS as a career, I'd say that what did me a favour was becoming a CCP first, but only because it consolidated my CCP learning really well. So I was using the skills that I'd learned as a CCP and then being able to work alongside an advanced trauma doctor in sort of honing those skills and understanding what I've learned and putting it into practice. But a lot of people do it the other way around. So they do HEMS and then they'll go on to be a critical care paramedic. And that's fine too. I was just pleased with the way I did it. I think it was the right way for me, but everyone's different. The other things that you can do is get involved in clinical governance day. So visit your local HEMS teams, find out how you get on board with that stuff. That will be a really worthwhile thing for you to do anyway, whether you become a HEMS paramedic or not. You'll learn things, take things away with you. And as the team grow to know you and you get really bought into that system, you'll learn the things that we go through as part of the selection process in any case. You'll just sort of see how we're expected to behave, and that will make you stand out. And the other thing to think about is the DIP IMC. Again, if you've done the diploma in immediate medical care, when you put in your application, they'll see that and they'll think, okay, you've put yourself out, you've really tried to offer what they're looking for. So that will really help out with you as well. And that's sort of the best things that you can possibly do. Drill as well. So you can drill inside the ambulance service, just get little study groups of 4 or 5 people together, find one of your critical care paramedics or an ex-HEMS paramedic and say, look, can you come and do some moulage with us and training? Again, just getting into the habit of training with a mannequin, which I know you're doing at university anyway, but it will really help you out because it feels so artificial once you've been away from it for a while. And that kind of concludes the talk that I was going to do, but I'm happy to field as many questions as people would like.
Thanks, Dave. That's great. Yes, I will open the floor to questions. People want to have questions in the chat. I'll pause for a moment. I think one's coming in.
Yeah, Sarah's typing. And some more. Yeah, it's right. So, Sarah, that's one of the things people don't realise, because again, you see a helicopter and you think, oh, car crashes, trauma and things. I've seen that sepsis bundle do amazing things for patients that have got a neurosepsis. We start their treatment as soon as is humanly possible. The evidence suggests that the quicker we administer those drugs, the better those patients do. So for the rural ones, really good to bring the drugs to the patient's side. So yeah, it's one of the parts I really like, and it's also busy for a paramedic because they all require a bit of preparation. A lot of them are in powdered form, so you're having to reconstitute things. It is good, but there is a lot that we offer. There's a session that I've done in Richard's previous iteration somewhere else where I talk about everything that we do. So I'd be more than happy to come and deliver that, Richard, if you'd like me to. But I go into the depths of literally everything you could expect from an air ambulance and a critical care paramedic.
Yes, no, great, certainly. I'm happy to link you in with colleagues where appropriate. Yeah, certainly. I've got I know I can see William's typing as well. I've got a question. Sorry, a couple of questions. First one is, where do you see the future of HEMS going? So maybe from a system point of view, but also a clinical point of view.
So I've seen it changed an awful lot, since I've been there. So it's become far more doctor-led, and some people think that that's not such a good thing. But at the same time, we've gone from a system where we used to have rules like the paramedic never passes the tube. And it was something that we inherited from a very strict system that we grew from. Now the roles are completely interchangeable. So if I want to be the lead clinician for the day, we'll have a discussion beforehand. We work a language out between us so that the doctor can tell me if they want to take over from me. I have no ego about that at all. They're clinically senior to me. That's how it works. No problem at all with that. It doesn't really happen because we train absolutely in the same way for our initial HEMS phase. I think the paramedics do more, but I think a lot more of the background decision making is more physician led. And I think transfers, since COVID's come around, it's very American to transfer people in helicopters, but we've started doing an awful lot of critical care transfers. So moving patients, especially from East Kent into the London hospitals, because the advantages we offer are fairly obvious as far as the transport time goes. But then the other side of it is we offer the doctor-paramedic partnership with syringe drivers, a decent ventilator, anaesthetic drugs, and so on, so they don't have to send a doctor. And obviously the hospitals absolutely love that because they want their doctors to stay and work with them. I think that there are loads of innovations that are going to keep coming along, and I think it will just grow and grow. I can't see beyond transfers what the future is going to hold too much. I hope the evolution of more major trauma centres, so we're not always travelling as far. But transfers, I think, is where it's at the moment. That's certainly what we're working on. I'll grab another another one that's come into the chat before we do your next one, if that's all right. So, how busy are you? This is something I should have included in the presentation. To tell the truth, it varies. So I'm. You can probably tell because I talk fast and so on. I'm very hyperactive, and crikey, it drives me mad sometimes when we're quiet. You can do 12 hours without going anywhere, but in that 12 hours, that should be time that you spend making yourself a better paramedic. So if you do a 3-year stint on Air Ambulance Kent, Surrey, Sussex, you can complete a master's degree in that time, and you'll probably complete the whole thing at work. So you'd be able to write all of your essays and so on, probably in time that you're being paid for by the Air Ambulance Service. So there's advantages to that sort of thing. COVID hasn't really affected our dispatch much, but it has affected our practice. So obviously we only in the same way as the ambulance services really. So we've had to change some of the kit we use for rapid sequence induction to include closed circuit suction and things to try and stop any aerosol generating particles from affecting the helicopter pilots. We've also had to put in a fixed wall between the pilots and us in the helicopter. We used to be able to see out of the windscreen, and now it's blocked off completely so that they don't get any of the AGPs coming through to them and affecting them. Obviously, we now conduct RSI in full level 3 personal protective equipment. And that's weird as well because most of our work centres on what we call good crew resource management, being able to manage other people, talk to them, everyone understanding that they have a role and what they're doing. And if you've got a hood on and things, it becomes much more challenging. So I think they're about what's changed as far as COVID goes. Hasn't really changed the dispatch other than we're doing more transfers because obviously transfers became a very big thing with COVID and ITUs being full. And the practice, it's more about the PPE and the COVID precautions. A rough timeline could be from graduation to HEMS. I think that I've never known anyone do it in less than about 5 years, but there can always be a first, and that's not written down anywhere. I think it entirely depends just on how hard you work at it, how much you get known within the system, how much you come to their governance days, and so on. But you could do it as quick as you wanted. It's just about the effort that you want to put in. The qualification I recommended is what Richard's just popped into the chat. So this is something you self-study for, the DIP IMC. It is in addition to your BSc. And essentially, you self-study this. There's, what do you call it? I've forgotten the word. Richard, I've forgotten the word. Syllabus. There you go. The syllabus is contained online. And you can find what you need to study for it. And if you know JR Calc back to front, and there's another course that I can't remember the name of now. There's a advanced, that's it, ATLS, Advanced Trauma Life Support. If you know those inside out, you'll pass. And it's lots of again mini stations and a written exam paper. I do some ECGs and things. You do an awful lot of the trauma type moulages. If you pass that as well, it sets you into good stead for the HEMS application process because they're pretty much based around it. So it's a really good one to do. Costs money, so I think it's just under £1,000 for the exam that you have to completely self-study for. But it's taken very seriously. If I've been doing this an awfully long time. If I see DIP IMC after somebody's name, I am a little bit impressed with it, and I haven't done it.
Thanks, Dave. Just another one for me, just in relation to once, paramedics have achieved their HEMS dream, once they've spent some time working on an air ambulance, they might be sort of working as critical care paramedics, maybe in a trust. But what are the options with regards to the next steps in sort of career development from there?
So the next steps, the most logical next step if you haven't become a critical care paramedic before you join HEMS is to become a critical care paramedic if you decide that you like that type of work. So in CCAM, again, you apply after having, I think we're asking for 5 years postgraduate experience, and you know, all of that type of thing. It's just experiential rather than anything. The application process is really similar. And then we get you through. We now actually enrol you on a postgraduate diploma at George's, though I think they're looking at where we're doing that at the moment. And you join the CCP program. You work on a car on your own, and you're deployed to essentially the same sort of instance, but you have more medical involved in that. So I'd say I do more medical as a critical care paramedic than I do trauma. But a lot of that again is bringing the basics. You know, doing the basics really, really well, and seeing people who are just a little bit out of their comfort zone with patients. You know, just coming along and being a good, experienced paramedic for them. So that's one way. I had colleagues though. I've got 3 colleagues that have gone on to be advanced critical care practitioners in hospital as a result of it. So obviously they learn how to manage an anaesthetic. They learn how to manage the anaesthetised patient. They know how to deal with ventilator settings. Totally transferable into intensive care. So I've got 3 or 4 colleagues that have gone away and become advanced practitioners in critical care for hospitals. So that's quite transferable.
That's great. And am I right in saying an air ambulance paramedic might be traditionally paid a band 6? Your CCPs or your advanced paramedic practitioners, critical care brackets in London are sort of band 7 roles, salary wise. And then are the ACCPs paid more? That's a separate master's pathway, but no.
So a paramedic on HEMS is paid band 6, and the fact that you're a critical care paramedic doesn't mean too much, because what they want on the service, what they need, is a paramedic, and it's you know so that's the way they sell it. You're a HEMS paramedic, you're not a HEMS critical care paramedic. But if you're early in your career, it won't make much difference in any. So if you're an early band 7 rather, it won't make much difference in any case, because they overlap a little bit at the bottom of the band. And I've got colleagues that have been critical care paramedics that have happily gone down to band 6 to go and have a HEMS experience. But yeah, you're right. If you take an advanced role, so you become a critical care paramedic or an ACCP, so a critical care paramedic in CCAM is a band 7, the same as London. If you're an advanced critical care practitioner in ITU, it's an 8A, but you're a band 7 as a trainee. So when they take you on as a trainee, band 7, and then band 8A once you're qualified with your prescribing qualification. The other thing that you can do with it as well is they do advanced clinical practitioners in ED. They'll take you after that level of experience as a trainee advanced practitioner in ED. So that's another route for you, because essentially you're seeing the ED type of spectrum.
Yeah, no, that's great.
Heather's asked another question. So no, and it does cause skill fade, without a doubt. So the Kent Surrey Sussex system has recruited its paramedics directly for a while, due to an old issue with CCAM, for want of a better word. And some of their paramedics have now been there for greater than 7 years, and they would honestly say they wouldn't tell you how to operate on the back of an ambulance or anything like that. They'd need a package of training to get them back there. But we've also gone back to offering year secondments. So in the space of a year, you probably won't skill fade too much. And what you can also do is you can pick up overtime shifts and so on. And they'd be very reasonable with you if you said you wanted to still work on an ambulance. So you do get lines on the rotor that are designed to just be you developing yourself. And if you said, like, my development will be I want to stay competent on the back of an ambulance, they'd be like, oh, that's fine, no problem at all. It's just most people who come to HEMS get the bug for HEMS and just want to work on a helicopter for a while. Yeah, I think it would, Jake. It depends what you're bringing along, and what sort of involvement with the military you've done. So if you've been a combat medic, again, they'll like that. If they see that on a CV, they'll be pleased with it, because at the end of the day, you've been trained in doing trauma in austere conditions. And actually, some of what we do can be pretty austere. Not commonly, but you know, if it's one of those great British winters where it snowed like mad and it's freezing outside, and then somebody's been laying on the ground for the last hour and you need to do the anaesthetic before you put them in the helicopter, it can be pretty challenging sometimes. So yes, it would look favourable, but I'd still recommend carrying on along the pathways described. So DIP IMC, really, really useful, or just getting very involved with the HEMS teams, asking to come to governance days. Don't expect that you'll be able to come to everyone that they do, but if you attend like 3 or 4 a year, most of them won't turn you away for that.
That's great. Thanks, Dave. Any other questions from anyone that wants to put the hand up or pop something in the chat? I'll pause a moment just in case anything else comes in.
I'm glad it's been helpful. I always worry when I do these things that they're going to be like, what, really?
Another question from Kate, actually. That's a good question. Great Western Air Ambulance Charity, I think, ATM.
So I can't speak for Great Western because I'm not very aligned with them at all. But what I'd say is go on their website. They'll have a contact us button. They almost all have that universally. Just basically write them an email and say, do you run clinical governance days? I'm sure Great Western does. They're very pro double paramedic, and they've actually got paramedics giving blood products and things. So they're quite advanced for the paramedics. Have a chat with them, and I'm sure they'll make you feel welcome.
Thanks, Dave. That's great. Well, if there's no other questions, what I have done is I'll put a link to a survey for those that are present. If you wouldn't mind spending 2-3 minutes of your time just to give us some feedback around today's session, but also to help us gauge the impact of today's session moving forward, and obviously have an insight into what you think future sessions could look like. So certainly, Dave, thank you very much. I think it's been extremely useful and valuable to hear your thoughts, and especially around the DIP IMC, because that's certainly something I think a lot of people maybe are not aware of or haven't considered, because they're just looking at university and academic credits, and that sort of sits aside it, but it's obviously equally, if not more valuable by the sounds of it. So
it's really useful if you want to do trauma care, and again, if you're going for a training critical care paramedics job within one of the ambulance services, again, it will set you apart from the others. Yes, it's money, but do you know what? You'll take a lot away from it. It kind of forces you to self-study and then take an exam at the end of it. But you know,
yeah, that's sort of got you there between the eyes. But no, that's great. Thanks, Dave. I will stop the recording, and we'll make it available to